Good afternoon, Ajahn. It's my great honor today to present my thesis proposal with the title Effects of High-Intensity Inspiratory Muscle Training in Patients with Heart Failure with Mildly Reduced and Preserved Ejection Fraction, a randomized controlled trial. The outline that I would like to cover today includes introduction and literature review, gaps of knowledge, research questions, research methodology, and statistical analysis. I'll start off with the introduction and literature review. Heart failure is a common condition, which is a big problem worldwide. The prevalence of heart failure in general population is 1 to 3%. It means that over 240 million people were living with heart failure in 2022. If you look at the mortality, you could see that over half of heart failure patients die within 5 years, and the annual healthcare cost for heart failure patients is up to 25,000 euro or over 900,000 Thai baht. Let's take a look in Thailand. Heart failure prevalence was estimated to be 0.4%. In Thailand, the heart failure hospitalization still increases, and the annual healthcare cost for heart failure patients was 120,000 Thai baht, and the hospitalized heart failure care cost was 250,000 Thai baht. As you may know that heart failure is a big problem, so let's move on to the classifications of heart failure. Heart failure could be classified into 3 types: heart failure with preserved ejection fraction, heart failure with mildly reduced ejection fraction, and heart failure with reduced ejection fraction. Heart failure with preserved ejection fraction is defined as the presence of symptoms and signs of heart failure, plus left ventricular ejection fraction equal or greater than 50%, plus the evidence of cardiac, structural, and/or functional abnormalities addressed or with exercise. The definition of heart failure with mildly reduced ejection fraction is similar to heart failure with preserved ejection fraction, except the left ventricular ejection fraction is in between 40 and 50%. Let's take a closer look at heart failure with preserved ejection fraction and mildly reduced ejection fraction. In this figure, on the left-hand graph, the vertical axis shows the proportion of patients with heart failure with preserved ejection fraction. You could see that the trends of prevalence of heart failure with preserved ejection fraction increase over time. On the right-hand graph, the y-axis captures the number of admissions. You could see that the red line shows the number of heart failure with preserved ejection fraction continue to increase, while the black line shows the number of heart failure with reduced ejection fraction seems to be the same. In this cohort, you can see that more than half of patients with heart failure were mildly reduced and preserved ejection fraction, and the 5-year mortality rate of those patients were not different from the heart failure patients with reduced ejection fraction. And again, the 5-year mortality rate in this cohort was 75%, and the mortality rate in readmission was up to 97%. One of the most common problems of heart failure with preserved ejection fraction and mildly reduced ejection fraction is exercise intolerance. So let's go further on it. What is exercise intolerance? It is defined as a complex clinical syndrome represented with reduced oxygen consumption, or VO2, during physiological stimulation. Oxygen consumption will be affected by cardiovascular, pulmonary, and muscle structure and function. So, how to diagnose exercise intolerance? Firstly, the cardiopulmonary exercise test, or CPET. It is a comprehensive test, combines exercise with measurements of various physiological parameters, such as heart rate, blood pressure, oxygen consumption, carbon dioxide production, respiratory rate, ventilation, and electrical activities of the heart. During the test, the work rate will be incremental and the peak oxygen consumption is determined as the highest oxygen consumption achieved when patients reach maximal effort during the test, and peak oxygen consumption considered normal when it is equal or greater than 85% of predicted value, or greater than 20 millimeter per kilogram per minute, and abnormal when it is less than 85%. The evidence of exercise intolerance in patients with heart failure with preserved ejection fraction is shown in this figure. You could see that the average of peak oxygen consumption is in these patients is around 15 millimeter per kilogram per minute, which is less than 20 and below the normal range. In addition, many activities of daily living, such as dressing, making bed, or walking, which is easy for healthy adults, require near maximal effort at the lactate threshold for patients with heart failure with preserved ejection fraction. Another test to evaluate exercise intolerance is 6-minute walk test. It is a simple and commonly used objective assessment method in clinical practice. The patients are instructed to cover the maximum distance possible in 6 minutes at a self-graded walking speed and pausing to rest when needed. 6-minute walk tests provide information about the distance, patient's exertion, and the adaptation of their cardiopulmonary system during and after the test. The patients with 6-minute walking distance less than 300 meters will have higher risk of mortality. Let's take a look deeper in the pathophysiological abnormalities contribute to the clinical manifestation of heart failure with preserved ejection fraction. Risk factors such as comorbidities, aging, obesity, physical inactivity, and systemic inflammation lead to downstream of multi-organ dysfunction, fatigue, cardiac dysfunction, and skeletal muscle myopathy, which is resulting in inspiratory muscle weakness and exercise intolerance. The inspiratory muscle weakness is explained by some mechanisms, such as respiratory muscle atrophy, changes muscle fiber types, muscle metabolic reflex, reduced oxidative capacities, ventilation inefficiency, and physical deconditioning. So, from the previous section, you could see that inspiratory muscle weakness is a key contributor of exercise intolerance. Let's further explore the status of inspiratory muscle weakness in heart failure with preserved ejection fraction. The prevalence of inspiratory muscle weakness in heart failure with preserved ejection fraction is 30 to 40%, and inspiratory muscle weakness is defined as maximal inspiratory pressure, or MIP, less than 70% of predicted value. MIP test is a measurement used to assess the strength and function of the inspiratory muscles, particularly the diaphragm. The graph shows the pattern of a maximal inspiratory pressure test. The vertical axis represents the pressure in centimeter water, and the x-axis shows the time. The tracing in the graph represents the process of a maximal inspiratory pressure test. Patients are instructed to expire maximally before inhalation forcefully at residual volume to against an occluded airway and maintain the effort in 2 seconds before exhalation. The maximal inspiratory pressure is determined at the plateau of the tracing right here. Generally, the normal MIP is around 100 centimeter water. In clinical practice, inspiratory muscle weakness is considered as a poor prognostic factor in heart failure. This figure represented the survival rate of heart failure patients with inspiratory muscle weakness by the red line, and those without inspiratory muscle weakness by the blue line. You could see that patients with inspiratory muscle weakness had a significant lower survival rate than those without inspiratory muscle weakness in both heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. So, what is the solution for the inspiratory muscle weakness? An effective way to strengthen respiratory muscle in patients with heart failure with preserved ejection fraction is respiratory muscle training. In this method, inspiratory muscle training with resistance training is of great concern because inspiration is generally an active progress of diaphragm activities, and it plays a vital role in oxygen uptake efficacy. In addition, the resistance training device is user-friendly and more cost-effective than other devices. While the patient trains with the inspiratory muscle, the inspiratory muscle training device will provide a stable resistance while inhalation, and patients need to inhale strong enough to get over that threshold. So, how inspiratory muscle training could improve functional capacity? Inspiratory muscle training directly strengthens respiratory muscles, including diaphragm and the intercostal muscles. By that way, inspiratory muscle training improves the pulmonary function, which is one of the most important factors to increase peak oxygen consumption, as I told you. And it means that the functional capacity is improved. In order to gain expected outcome, the inspiratory muscle training program will be set based on three components: intensity, frequency, and duration. The intensity depends on the percentage of maximal inspiratory pressure and divided to high intensity, moderate intensity, and low intensity. An appropriate intensity is very important to optimize the outcomes. For example, patients with heart failure with preserved ejection fraction will have higher functional capacity compared to heart failure with reduced ejection fraction. So they will need a train at higher intensity. There are some previous studies of inspiratory muscle training in heart failure with preserved ejection fraction. Until now, only 2 trials were performed to evaluate the efficacy of inspiratory muscle training in heart failure with preserved ejection fraction. But both studies used low to moderate intensity of IMT. In addition, they use unblinded trial design, small sample size, and lack of report of the compliance to home-based IMT program. An interesting finding is no previous study evaluated effects of inspiratory muscle training in heart failure patients with mildly reduced ejection fraction. So the gap of knowledge is that there has been no study conducted to evaluate the effects and safety of high-intensity inspiratory muscle training on patients with heart failure who have mildly reduced and preserved ejection fraction. Based on the current evidence, we propose 2 novel research questions. Firstly, does the home-based high-intensity inspiratory muscle training program increase peak oxygen consumption from baseline more than that in sham controls in patients with heart failure with mildly reduced and preserved ejection fraction? And the second question is the home-based high-intensity inspiratory muscle training program safe, and does it improve maximal inspiratory pressure, 6-minute walking distance, quality of life, and echocardiographic diastolic parameters? So we conduct this study with two objectives. The primary objective is to evaluate the effect of the home-based high-intensity inspirator muscle training program on an increase in peak oxygen consumption from baseline in persons with heart failure with mildly reduced and preserved ejection fraction compared to sham controls. And the secondary objective is to evaluate the safety and the effects of the home-based high-density IMT program on improvements of maximal inspiratory pressure, 6-minute walking distance, quality of life, and echocardiographic diastolic parameters. And we hypothesize that the home-based high-intensity inspirator muscle training program increased peak oxygen consumption from baseline more than that in sham control in patients with heart failure with mildly reduced and preserved ejection fraction. And the program is safe and it improves maximal inspirator pressure, 6-minute walking distance, quality of life, and echocardiographic diastolic parameters from baseline more than those in sham controls in patients with heart failure with mildly reduced and preserved ejection fraction. This is my conceptual framework. Patients with heart failure with mildly reduced and preserved ejection fraction will present with inspirator muscle weakness, which is also affected by other factors such as aging, nutritional deficiency, obesity, medications, and comorbidities. And inspirator muscle weakness, inspirator muscle training will have to increase the strength, speed of shortening, power output, and endurance of inspirator muscles. By that way, inspirator muscle training could improve peak oxygen consumption and other outcomes. There are some confounders that could affecting the oxygen consumption like beta blocker, gender, and inadequate exercise. I have just explained the reason why I look forward to conducting this research. Now, I will proceed with clarifying the method for undertaking it. Firstly, the study design. We use randomized control trial design. The patients with heart failure with mildly reduced and preserved ejection fraction will be assessed for eligibility. They will be excluded if they meet exclusion criteria. Then they will be randomized and stratified into two groups, high intensity IMT and sham IMT. After 8 weeks, the primary endpoint and the secondary endpoints will be evaluated, and I will be detailed on it in the future. The eligible criteria. I will include the patients with that diagnosis of heart failure with mildly reduced and preserved ejection fraction in the medical records with age 18 or older and NYHA class 2 and 3. The patients need to be stable with dose of heart failure medications within 4 weeks. And the exclusion criteria are gait problem, worsening symptoms and signs of heart failure requiring intensification of treatment, recent angina or open heart surgery, end-stage renal disease, post-heart transplantation, anemia, moderate to severe valvular disease, significant primary pulmonary disease, systemic disease like amyloid or sarcoidosis, and comorbidities with life expectancy less than 1 year. And some withdrawal criteria are as presented in this slide. To ensure the randomness and blindness, we use block randomization method with a block of 4 and 6 in a 1:1 ratio into 2 groups. The outcome measurement and data analysis researcher are blinded to the intervention allocation. Participants are blinded to one other intervention. The intervention protocol. The high intensity will be performed with warm-up in 5 minutes. And the training resistant will be set at 30% of MIP in the first week, 50% of MIP in the second week, and 70% MIP from the third week. And the cooldown will be performed in 5 minutes. The sham IMT warm-up and cooldown will be performed similar to high-intensity IMT. The training resistance will be kept at 15% of MIP during the period of intervention. This device will be used in this study. It includes 11 adjustable levels of resistance corresponding to the resistance from 17 to 98 centimeter water. This is my study endpoints. The primary endpoint is the change in peak oxygen consumption at 8 weeks. And the secondary endpoints are maximal inspiratory pressure, 6-minute walking distance, quality of life, diastolic function, and experience of some adverse events. I propose some ways to manage patients' compliance, include logbook, phone calls every week, and a checklist. This data collection timeline from the admission to the end of the intervention. All this data will be collected during the first meeting by me when patients are eligible for the study. Additionally, they will be taught the training program prior to the study by a physiotherapist. To ensure that the intensity is maintained at the target level, patients will undergo reassessment of MIP at the beginning of the second, third, and fifth week in order to adjust the training resistance. All the outcome will be collected again at the end of the study. For the sample size calculation, we set the power of the study at 80%, the alpha level at 0.05. The results show that we need 12 participants per group and 24 patients for 2 groups. I assume that 15% of patients will drop out of the study. So total participants is 29. The statistical analysis. Intention to treat analysis will be considered. The normality of the data will be examined by Shapiro-Wilk test. The statistical significant level is p-value less than 0.05. The table shows the number, the outcomes, and the statistic tests I use for each. Independent t-test and chi-square test will be used, depends on the types of data. The limitations. Some problems with compliance could arise, but we use phone call every week and diary to alleviate the limitations. I intend to apply for the 90th anniversary of Chulalongkorn University scholarship to serve my study. The ethical issues. Firstly, cardiac rehabilitation is not implemented as a mandatory routine in the King Chulalongkorn Memorial Hospital. So, comparing a high-intensity inspirator muscle training program with sham controls allows for a fair comparison to the usual care while ensuring a non-biased and blinded study design. We also provide consent form and opportunity to ask any question. Participants can withdraw from the research at any time. This is my study timeline, and I'm in the first stage. Thank you very much for your attention. I look forward to receiving your suggestion to help improve my thesis. Thank you very much.